Well, hello, everyone. I'm Tim Naimi. I'm the director of the Canadian Institute for Substance Use Research in Victoria, British Columbia, Canada. And today I'm going to be talking about alcohol's impact on states and municipalities and giving you a bit of public health and clinical perspectives. So as a brief outline, I'm going to talk about alcohol consumption in the United States, including the different definitions and dimensions of alcohol use. I'm going to talk about the health, social, and economic impacts of alcohol use. And then I'm going to talk about risk factors for problems like community level factors, genetic factors, personal characteristics. Then we're going to cover off on some of the things what we can do to prevent or reduce alcohol related problems. And then I'm going to talk in particular about alcohol policies, which are, after all, laws, as cornerstones of solutions to alcohol-related problems, including those pertaining to mental health problems. So because the focus of the conference is mental health, I wanted to give a particular sort of focus on alcohol's role in mental health, because it can affect multiple forms of mental health in an adverse sort of way. So alcohol is most likely one of the causes of depression, and in addition, it can be a clear exacerbant of depression, meaning people who may have developed depression having nothing to do with alcohol, it can be made worse by alcohol consumption, particularly excessive drinking. For these same reasons, alcohol is intimately involved with suicides. Depending on the study, anywhere from 30 to 50% of all suicides will involve alcohol at some level. And this is in part because when people are impaired with alcohol, they tend to do stuff that they wouldn't otherwise do, even if they felt like it at the moment. Then we have to remember that alcohol use disorder, or in the old parlance, alcohol dependence or alcoholism, is actually a type of mental health condition, or is described as such. In the short term, alcohol leads to emotional lability, means changes in emotion, impairment in judgment, can lead to anger, with verbal and physical abuse and violence that might not have otherwise occurred in the absence of alcohol. Alcohol contributes to sleep disturbances, interpersonal relationship problems. It can interfere with medication adherence. So people who are drinking excessively or heavily may not take medications. Again, this is another way that alcohol consumption can influence mental health conditions that involve taking pharmaceutical products. And then alcohol can definitely contribute to job problems. Now, job problems are not, strictly speaking, mental health, but again, a lot of these kind of existential things like our jobs and our relationships are intimately related to mental health, which is why I mentioned them. Well, what about the public health of importance of alcohol, and in particular relative to other substances? So when I think about public health impact, I think about, that means like how many deaths, how many injuries, how many problems does it cause? Then I think about what is the preventable fraction? In other words, something that has more public health value is something we can do something about. And then I also think about secondhand effects, because those are particularly important when the people other than the drinker, him or herself, are suffering consequences. So alcohol, of all the kind of most commonly used substances, causes lots and lots of deaths and injuries and problems. We'll go into that a bit more. But in terms of total deaths, it probably still trails tobacco. But even now, alcohol causes many more deaths, for example, than do opioids, and certainly marijuana, obviously. In terms of the preventable fraction, for tobacco and alcohol, the preventable fraction is high. Why do I say that? Well, it's because both of those substances are legal, and therefore we have a series of laws and policies and regulations that surround the use of these substances that can be dialed up or down to control how much is consumed in the population. And then alcohol in terms of secondhand effects, is definitely the king of the substances, because lots of alcohol-related violence, sexual assaults, child abuse and neglect are tied closely to alcohol. So I'm not saying that other substances don't cause, heartbreak or problems for other people, but alcohol is the leader of the pack. Well, one of the problems in my field is that the definitions and measurement of alcohol consumption are all over the place. So if you're feeling confused by all the terminology, don't feel bad, because a lot of people are. So I'm going to talk about a few things today. One is per capita consumption. That's sort of saying, what is the sales of alcohol, and assume the consumption for the total population as a whole. Current drinking usually refers to any consumption. It can be in the past month, or it could be in the past year. Binge drinking is an important term, and refers to levels of drinking that result typically in alcohol-related impairment. So that would be 5 or more drinks for men, or 4 or more drinks per woman on a drinking occasion. Note that this basis for the binge drinking definition is not to do with average consumption, but it is consumption that is clustered in time, if you will. Now, just to confuse things, in the context of heavy alcoholism, or in the context of addiction medicine, binge drinking is often used in a different way to describe like a long period of drinking, like going over days, but I'm just going to mention that as something to be aware of. But in the common parlance, it's sort of drinking to the point of impairment. Heavy drinking is a term that's used by the Centers for Disease Control, which refers to levels of average consumption in a day or in a week. Moderate consumption is a term that's thrown around a lot, but there's not really a definition of it. And a lot of people will use the idea of drinking in moderation to mean sort of low-level drinking, but it really depends a lot on who's using the term. There are also, from the dietary guidelines, there's also recommended limits for people who consume alcohol. And it's how to consume alcohol in a reasonably low-risk way for most people. And that's up to 2 drinks per drinking day for men, or 1 per drinking day for women. And then there's alcohol use disorder. We've mentioned that in the past already in this talk. That's a clinical diagnosis, and it's based on having 2 or more out of 11 criteria, having suffered problems or showing signs of tolerance or withdrawal, these types of things. So these first measures are based on how much someone is drinking, and then the alcohol use disorder is more based on a clinical diagnosis. This is a slide that shows per capita consumption in the United States. On the y-axis, on the left there's the number of gallons of pure ethanol consumed per person aged 15 and older in the US population. And what I want, this goes way back all the way to the 1930s, so shortly after the lifting of prohibition. You can see that consumption really went up, but I want you to focus on the last 20 years, that consumption has increased about 10% between 1995 and 2015, and it's actually continued to go up. So you can say, well, that's only a difference. It went from like 2.1 gallons of ethanol per person up to, now almost 2.4 or 2.3.5. And even though that doesn't sound like a big difference, it actually translates into big differences health-wise. This shows you the per capita consumption by state. If we look at these same views, this is from 2016, for example. The states that are the bright red have the highest consumption per person in the population. So these tend to be the West, the Intermountain West, the middle of the country, and the Northeast, the Midwest and the Northeast, with lower rates typically observed in what some people would call the Bible Belt and in the Southeast. Now, there's an important concept I want you to get across to you, which is this idea of the drinker's pyramid. So before we get into what the specific labels mean, if we think about this pyramid pertains to, let's say, people who are drinking in the general population. In the United States, at the bottom there are about 35 or 40% of people who really don't drink alcohol at all in the past month or past year. A lot of those people have never consumed much alcohol, but more than half of them are actually what's called former drinkers. Some of them may have, sort of drank too much and quit drinking, or some of them may have become ill or older and just stopped drinking because it's not as pleasurable. Then there's like 35% of people, we might call them low risk drinkers, or people who are kind of not, meeting criteria for binge drinking, and they, maybe have one or two drinks most days that they drink. Then we have your high risk drinkers. And then at the very top of the pyramid, we have the alcohol use disorder, or the people with probable alcohol dependence. And that's about 5% of the population. Now, what we're going to talk about today is that typically people have just focused on the 5% at the top. But if you want to do prevention, and you understand that a lot of the problems are actually coming from that 20% right below the 5%, you need to focus on both of those people. You need to focus on the high-risk drinkers and people who have alcohol problems. Again, not only because the high-risk drinkers are contributing quite a bit of problems, but because today's high-risk drinkers are going to become tomorrow's people with alcohol dependence, or may become those people. And once you have people with alcohol dependence, even though, we try to treat them, or they, hopefully a lot of people, aren't interested in treatment, and treatment is not always effective. So we really would like to, in this talk, really the whole concept boils down to intervening with people before they get to the top of the pyramid, if that makes sense. Now, thinking about prevention and different things, that's the way we think of binge drinking. In the same way that high blood pressure is a risk factor for heart failure and having a stroke and getting hardening of the arteries or this and that, so too I want you to think about binge drinking, not as a disease in itself, because it's not, but it's a form of high-risk drinking that increases the likelihood of alcohol-related problems, or directly causes lots of alcohol-related problems, including among people who are not otherwise meeting the definition of alcoholic or having an alcohol use disorder. So binge drinking is a strong risk factor for things like injuries, even certain types of liver disease, violent sexual assault, we've mentioned. Actually, cardiovascular disease, people are more likely to have heart attacks when they're binge drinking, or have been, and different things. So if you want to think about this, I would put kind of binge drinking as, if you will, as the fundamental building block of alcohol-related problems, whether or not alcohol use disorder is there or not. So in terms of health impacts across the country, alcohol contributes about 106,000 deaths annually in the US. And again, that's compared to about 50 or 60,000 now from opioid overdoses. It's the third or the fourth leading behavior-related cause of death. Each alcohol-related death causes about 30 years of potential life lost. And that is because, of course, many of these injury deaths from alcohol occur among youth and young adults who have many years of life ahead of them. This would contrast to something like tobacco, where most of the deaths from cigarette smoking, or a lot of them, are caused by heart disease and cancer, which tend to affect older middle-aged adults and older adults. So that if you look in terms of the years of life lost, actually alcohol causes more of those than does cigarette smoking. Economics, I'm not going to go into great depth, but alcohol, excessive drinking costs about $750 per person in the United States, not just among drinkers, but if you were to spread that out among each and every person, or about $2 per drink if you were to divide the costs among all the number of standard drinks sold. And I should mention that, remember, a beer has the same amount of alcohol as does like a standard 5-ounce glass of wine, as would a shot of, whiskey or something like that. So each standard drink costs about $2 in terms of costs for health problems and problems from the legal system, and etc. Let's look at the breakdown. Now, this is a slide just kind of showing the approximate breakdown of deaths just from excessive drinking. So this total here is about 88,000 deaths from excessive drinking. I just mentioned that there were 106,000 deaths from drinking overall. That's because there are some deaths actually that come from quote unquote moderate drinking or drinking at low levels, certain cancers, including breast cancer, for example. But let's look at deaths from just excessive drinking. We can divide these into two main pools. The first is the acute causes of deaths, or things that are basically happening because someone's intoxicated. So those would be like motor vehicle crash deaths, injuries, violence. Those total about 43,000. And then we call them the chronic causes of death, which is a cumulative effect of alcohol's toxicity to various tissues in the body. So those would be alcohol-related liver disease deaths, CVD is cardiovascular disease, and then the alcohol-related cancers, another 19,000 deaths a year. So that comes, so about a pretty close to an even split between acute and chronic causes of death from alcohol. And then the secondhand effects, I think I've mentioned them, but these would be like pedestrian injuries, somebody walking on the sidewalk is run over by an impaired driver, people who are injured in alcohol-related fires or homicides. There are things on society like a lot of economic costs. There, pretty much all of the effects that happen to children are by definition secondhand. These would be like financial problems or child abuse and neglect. And of course, there's the effect on fetuses. Alcohol is the leading neurotoxin among America's children, and probably about 4 to 5% of all pregnancies in the United States are alcohol involved. And the other key point to take away about that is that fetal alcohol syndrome is the full-blown kind of thing, but it's important to remember that there are lots of alcohol-related effects, even among people or even among kids who aren't diagnosed with the full FAS. So there's now this whole concept of FASD, fetal alcohol spectrum disorder. So a lot of things like certain learning disabilities and so forth caused by alcohol exposure in utero, even if you don't have the full syndrome of fetal alcohol syndrome. This is another way to look at the harms to others. This is a paper from not at all from England from a few years back. But if you look at the ratio of the red bars to the blue bars, the blue is the harm to users, and the red is the harm to others. And you can see that as a ratio, not only is the total harms from alcohol more than from all those other substances, but a greater fraction of the harms occur to people other than the drinker, him or herself. Now, I kind of gave you a hint about this earlier, but the traditional paradigm around alcohol we've been rooted in this, what we call the biomedical model. And to simplify things greatly, in this case, the problem of alcohol was alcohol use disorder or alcoholism, and the solution was specialty treatment. But I'm here to kind of tell you that this kind of paradigm is kind of changing a bit. I think it's important to be very honest about the problems with the way the problem and the solution are conceptualized. And I mentioned some of these earlier. The first is that there are a lot of harms that come from alcohol consumption that come from those who don't have an alcohol use disorder. So, all that binge drinking that goes on in people who may not meet criteria for having an AUD and all those problems. And remember, that group of people is 4 or 5 times as numerous as the people with an AUD. So you've got a lot of problems that are caused by people before they even get to the stage of an alcohol use disorder. So from that standpoint also, if you're just focusing on people with AUD, well, you're kind of late to do any prevention, right? So we, again, would like to focus on people before we get to that stage. An example that I use frequently in talks is the idea of deciding to treat, we don't wait to treat people's high blood pressure until they have a stroke, or we shouldn't, right? We recognize that high blood pressure is a risk factor for having a stroke, and we try to treat the high blood pressure before the stroke occurs. Well, the same thing we want to do is prevention, is when we recognize that people are drinking in risky or unhealthy or heavy ways, we want to intervene then, before they get to having an AUD. The other problem is that if we wait until people have an alcohol use disorder, we have to remember that relatively few people with an AUD engage in treatment. They may not have health insurance. Even if they do, they may not get into a treatment program. The treatment program may not meet their needs or kind of fit in their kind of what they're looking for. And so the result of that is, the bottom line is that treatment is expensive and it's difficult, and actually a relatively high percentage of people with an alcohol use disorder have never had treatment. And actually a lot of them are not interested in treatment. And we definitely need to make treatment more attractive and more available, but that's not going to solve the problem. So I want you to think more broadly. We have a clinical box. I'm a doctor. We've had this biomedical model, and as doctors, we love to think about, okay, we're going to bring the person with the severe alcohol problem. We're going to treat them in the clinic. We're going to maybe admit them to the hospital. And then unfortunately, we have the morgue when that doesn't work. But really, what we really need to be understanding is all these non-clinical factors that are strongly influential to whether people drink alcohol and how much they drink. And I've just kind of thrown a few of these into the slide, like people's, the social attitude in the community, people's family history, their housing situation, how high the alcohol taxes are in their state, whether they, spend a lot of time exercising or have, a high amount of happiness, or they watch a lot of advertising. All these things matter. Their religion matters a lot. If you tell me somebody's kind of religious, family religious background and kind of their age and sex, you can often make a pretty good guess about, whether they drink alcohol or how they view it. The other thing we have to think about along these same lines is the difference between clinical and public health approaches. And what I'm going to hopefully convince you today is that even though we need to have clinical approaches to people with diseases like alcohol use disorders, we also need to take a public health approach to make a dent in this problem. When I say clinical, I mean we're oriented around patients with diseases, and those diseases are in need of treatment. But when I talk about public health, we're thinking about the whole population. We're thinking about risk factors within the population, be they alcohol specific, like binge drinking, or maybe not alcohol specific, like living in unstable housing, whatever it might be. And we think about prevention, not just treatment. So I think you're seeing where I'm going. The emerging paradigm is that alcohol is a cross-cutting risk factor, not a disease, but a risk factor for multiple health and social problems, including alcohol use disorder, but certainly not limited to it. We also recognize that the problems don't just come from the extremes of the population. In other words, it's not just kids drinking that's the problem. It's not just alcohol dependence that's the problem. And it's not just the quote unquote hardcore drunk drivers that are the problem. So the new paradigm, we focus on, drinking more than is healthy or excessive drinking. We look at the continuum of risk, that, the idea that risk is really starting to build up before we get to the point where, somebody has an alcohol use disorder. And we've really got to focus on fixing the things that we can fix. And what I'm going to tell you is that the easiest thing to fix that has the biggest impact is changing the environment in which we all may live. So next I'm going to talk about fixing the environment, and I'm going to focus in on alcohol control policies, because that's my area of expertise, and that is, I think, when you take the public health approach that I'm talking about, that is the key to the public health approach. Well, what are policies? Policies are typically laws that are passed, or they may be the regulations that attend laws. But this is the nice thing for this conference is that policies, for the most part, are legal constructs. So they're amenable to change, and they are firmly rooted in the law. By policies, I'm talking about things like alcohol taxes, or minimum prices for alcohol, or limits on the number of outlets where alcohol can be sold. Like, do we want alcohol to be sold in every kind of store, in every kind of place all the time? So in most states, there are limits on the number of outlets, or limits on the hours of sale, or the days of sale. Then we have things I'll call on-premise policy. That was like when you're consuming alcohol in a restaurant or bar. Are there restrictions on happy hours? Like, is there a restriction on saying if paying $10 and drinking all the beer you want? And then policies about like making sales to or people who are already intoxicated illegal. Then there's sort of drinking and driving laws, policies that people would be familiar with, like .08 laws and all the legislation surrounding those, ignition interlock laws. And then there's a bunch of stuff that pertains specifically to youth, the most important of which is minimum legal drinking age laws and how those are implemented and in some cases enforced. Well, I've worked in this field for about 20 years now, and so because policies are effective, but because they lead to reductions in consumption, there's a lot of attack on policies because there's a lot of money to be made from selling alcohol. And when people suggest interventions that might reduce the sale of alcohol, that generates pushback. So the first thing that that I hear a lot is that policies don't work. But I'm here to tell you, and I'm going to show you some research later on, that in fact policies work, and changing policies like raising taxes, reducing the availability of alcohol a bit by not making it available in so many places at so many hours of the day, those have big impacts. And they're actually impacts that you can measure at the population level. Like I can actually show you, listen, the number of people who binge drank in the whole population went down when the taxes were raised, or things like that. And then other people will say, well, policy, that's the kind of government, nanny state, and it's really about people being educated and making their own responsible decisions. And the answer to that is that the purpose of public policies around alcohol, just like it is around taxes or any other kind of thing, is to allow people to have personal liberty, but to help guide their decisions. So in other words, if people recommend, say, drinking a little bit of less alcohol, one of the ways to kind of unconsciously incentivize that behavior is to maybe make it a little more expensive or a little bit less available. So the purpose, because alcohol is obviously a legal substance, so our country or our state or our municipality benefits by keeping it legal, but also benefits by keeping it under control. Then other people will say, well, why can't we just, tax alcohol for people who have problems? And the answer to that is, well, these policies that are designed to affect the whole population actually impact the high-risk groups a lot, and in some cases the most. They help keep people who are drinking in low-risk ways, low risk. And as we've discussed before, it's not just the high-risk groups, highest risk groups that contribute all the problems. I think we've already touched on these. Alcohol policies may limit freedom or choice. And I think the way that people in the field look at it is that, in fact, they promote personal choice by making the sale of a dangerous product more acceptable. In other words, before we had alcohol policies, we had prohibition, which was, not socially acceptable to many people, and it was repealed. But as a condition of lifting prohibition, basically states were charged with saying, okay, we're going to make it legal, but now we got to make it safe for most people who drink, and particularly for people who don't drink. So that is part of a way we can do it safely is by regulating things. And then the other thing is the freedom argument. I mean, there's a big idea about freedom in our country. And but it's important to note there are two kinds of freedom, right? There's the freedom to do certain things, but there's also the freedom from having things happen to you, right? So we want to have people free from the fear of being run over by a drunk driver or an impaired driver. So there are different concepts of freedom. And the last thing is you'll hear is that policies cost money. But again, if it's raising taxes and things, they may actually could make the government money. They can actually lower income taxes or property taxes. It just depends what the policy is. And I think we'll skip over this slide. And maybe this one too. So in summary, I'll make the case for alcohol policies. They can prevent or reduce multiple types of alcohol problems across the entire population. The good thing about them is that they do not rely on persuasion, willpower, health consciousness, or a sense of civic responsibility. And they can be cost efficient and in fact can be cost saving. Many policies, not all of them, but many policies, including some of the ones that I've mentioned, have strong evidence of effectiveness from multiple different study designs. And as I mentioned, they can yield population changes for the full spectrum of drinking patterns. So they can be beneficial for people with an alcohol use disorder, for binge drinkers, for underage drinkers. And again, they reduce multiple types of problems. So I'm going to talk a little bit about the work that my research team has done to look at what we call the state policy environment. So most policy researchers might research the impact of changing one policy, like the impact of, say, stopping the sale of alcohol at midnight, or something like that, or they would study the impact of the change in a tax. But what we need to do is remember is that in each state or municipal area, there's usually many, many different alcohol policies in effect at one time. And how do they relate to each other, and what is their cumulative impact? And so that's what led us to develop the alcohol policy scale for US states, and it goes by, for each state and year gets a score. Very briefly, what we did was we identified effective state level policies. We include 29 in our scale. We then rated the efficacy of each policy relative to the other ones. So we kind of give a higher weight to policies that are known to be particularly effective, and then not very much weight to those that are minimally effective. We then develop a way to assess how the policy is actually put into place, and then we add up those policies, 29 policies, after weighting them by their efficacy and how well they're actually implemented. And we come up with this thing called the APS score. So this is just an idea to give you, there's quite a bit of variety between the states. And the longer bars are ones with stronger, more restrictive policies. So Utah, Oklahoma, and this somehow come out blurry on the screen, but those states, for example, Pennsylvania had more restrictive policies, whereas I think it's North Dakota, Florida, and Wyoming are at the bottom. And so they have the lowest policy scores. Now, in our studies, what I wanted to show you is that we've looked at the impact of, what would be the effect of a 10% increase in that APS, that alcohol policy score, and a variety of measures. And what we find is, and what you showed there is the adjusted odds. That basically means in scientific terms is like, what is the likelihood of having a particular outcome? So for like at the top, if you live in a state that has a 10% stronger policy environment, that 0.92 means you're 0.92 as likely to have a youth be a drinker. So in other words, it's about an 8% reduction in the likelihood that any individual youth will drink alcohol. So it's about, and then we see very similar. So for youth binge drinking, again, it's about a 7% reduction in the likelihood. We also look at the relationship of 10% stronger policies for binge drinking among adults, for self-reported alcohol-impaired driving, for being in an alcohol-involved motor vehicle crash death in youth or in adults, or involving low BAC. What you can see here is that 10% increase results in an 8 to 10%, or increase in a stronger policy results in an 8 to 10% decrease in the likelihood of all those outcomes. And there's more. There's lower risk of cirrhosis of the liver if you have a stronger policy environment, of alcohol-involved homicides and intimate partner homicides, a lower risk of alcohol-involved suicides, and actually a higher risk at the very bottom there, that if you live in a state with a strong policy environment, you actually have a 15% higher likelihood of being able to achieve remission from alcohol dependence. So stronger policy environments make a big difference for people that have, had substance use problems or worked in the field, or, worked in as a, physician as I have. That the environment makes a big difference. That people's kind of circumstances and the number of drinkers they're around and the overall environment makes a big difference. And so in some ways, maybe our research isn't that exciting, but I think our research has really helped make this pretty clear. Now, one problem we have is if we look at, I've showed you what we think the impact of policies are, but if you look at the changes in policy subgroups over time from 1999 to 2018, you can see that for most of those, these are different groups of policies. Most of them have stayed flat. We haven't really increased the strength of our policies, except for that dashed line at the top, alcohol-impaired driving. So most states have been quite active in implementing new alcohol-impaired driving policies, even since 1999. Because of that, we've seen reductions in alcohol-related crashes. But one of the things we have to remember is that, alcohol-involved motor vehicle crashes account for less than 20% of all the deaths due to alcohol. So while it's great that we've done a good job of implementing evidence-based policies to reduce impaired driving, we really haven't done it with policies that affect 80% of deaths. And let's look at some specific policies that we know from, not just from our research, but from, like literally hundreds and hundreds of research projects and things that make a big difference. Alcohol taxes. Alcohol taxes in US states erode with inflation because they're based on a set amount per unit volume of alcohol. They're not based on a percentage of the price like a sales tax would be. So if they're not increased with time, they erode with inflation. But anyways, this slide just shows for alcohol taxes for spirits or liquor, that's the line at the top, for wine and for beer, have all declined by about 35% in inflation-adjusted terms over the past 25 years. So that's not good from a public health standpoint. And actually, it's not good from a raising tax revenue standpoint. And the other thing you can see is I just want you to know where that line ends, because what we did in this study is we translated all of these figures into the amount of tax per drink. So for like a shot of whiskey, the average state tax now is about only a nickel. And for wine and for beer, it's less than 4 cents per standard drink. I bet most people didn't know that, because most people hear from the alcohol industry that taxes are too high. So I bet most people in this audience would not think that paying a nickel for a shot of whiskey or a beer is very much in terms of taxes, particularly compared to the overall price. And then the other thing that you can look at is whether or not taxes, for example, cover alcohol-related costs. And the answer is that they don't. They don't come close. They cover about 15 to 20% of costs on average. So if you think about it, compared to what, if you live in, I don't know, if you live in the state of Georgia, whenever somebody buys a beer in Georgia, the state has to spend a lot more in costs than they take in tax revenue. So I've talked to you mainly about policies, but I also want to talk about, other things that get discussed in the context of addressing alcohol problems, just so you have a kind of a fuller picture. So people will often talk about the importance of personality traits or certain psychological factors or demographic factors like race or age, so forth, in terms of being associated with alcohol-related outcomes. And I would agree that these are established risk factors. The problem is with things like personality traits and psychological factors, they're very difficult to modify or very difficult to change. And if you remember at the beginning, I showed you a grid and said, public health value, what's valuable for addressing in terms of public health is stuff you can easily change. Now, it's not that nobody can ever change their personality but it's generally hard to do it, right? You can go and have many years of therapy or homework on yourself, but it's not easy to change your personality traits. And the problem even with that is it's like an individual level intervention. So it's very resource intense. Well, demographic factors like saying, oh, younger people tend to drink more, or this or that race tends to drink more. Well, these are things we can't really fix, right? So, and plus we know that alcohol taxes or effective policies work for all ages and they work for all races and ethnicities. So, and the other thing is that even if you find a subpopulation who's often at more risk, it's important to remember that they're probably still only a minority of the total risk in the population. Educational interventions to reduce drinking. These are, I put in quotes, easy, right? Because it's pretty easy to set up a little, an educational program in a school for the most part. Most people assume that they're effective, and they tend to be popular things because they don't involve, it's relying purely on kind of persuasion or knowledge. But again, if you in public health, I think it's generally widely accepted that the evidence shows that educational interventions, particularly by themselves, are not terribly effective. Again, because they're not applied, you have to keep, putting the program in place and paying for it. They don't tend not to have much of a population level impact. They might affect the school or the particular community where it's done, but it's kind of, these are not things that are easily to distribute to the whole population. The effects of educational interventions degrade quickly. It's sort of like after a week or two or a year, you have to redo it or it doesn't really stick. And so for those reasons, educational interventions tend to be very cost inefficient. Treatment is obviously important for many people, but I think we've mentioned some of the problems. That is that most risky drinkers are not actually dependent and wouldn't qualify for sort of inpatient treatment. The evidence of effectiveness of treatment, it's important to remember, comes from studies of people who are actually motivated to engage in treatment, so they're willing to enter studies. And so maybe compared to people who are like less motivated to enter treatment in the first place, they probably won't expect the same benefits. The medications we have for treatment of alcohol use disorders also are not game changers. They make maybe a small difference, but they're not, a cure-all. And I think we've also talked about that there's problems with how much treatment resources are available and of interest to people. Screening and brief counseling interventions are a much milder form of treatment, if you will. They're meant to be done even in the primary care provider's office, or can be administered by social workers. Their evidence of effectiveness is for people who drink too much, but they're not really probably enough or effective for people who have a severe alcohol use disorder. But again, here, even screening and brief counseling interventions have only a modest effect on participant drinking. It hasn't really been well studied to determine how much of a long-term effects it has on downstream harms. like having an alcohol-related problem in 5 or 10 years. They're very hard to implement in clinical practice. I used to work in a small hospital, and I was in charge of implementing a screening and brief counseling intervention program, and it was difficult. And again, so I think it's important to remember that some of these things are important, but are limited. Now, genetics is something we've all heard about in the context, most likely all of us have heard about in the context of alcohol problems. And however, here, again, the heritability for alcohol use disorder, for example, is at most 50%, and it's probably quite a bit less. And why do we think this? We think this because we've done studies of separated twins, and the twins may come from parents with alcohol problems, and then the twins can either go to households without them, or there's all different combinations. But genetics is probably overrated because, there's a lot more things that run in families besides genes, right? There's a lot of the behaviors. When we do these big fancy new genetic studies looking for statistical associations of genes with alcohol problems, we haven't really found many genes. And so some people call it, they think it's genetic, but it's, quote, missing heritability, like we can't really find out if it is or not. Anyways, even if we knew what gene or genes were involved in the likelihood of drinking too much, there's no gene therapy that's available, so what can you do? And even people who know that they're at high genetic risk for other problems besides alcohol, those studies have shown that just knowing that tends to have a limited impact on changing people's behavior. So in conclusion, alcohol causes big medical and social problems, including and especially mental health related issues. Alcohol use disorder, parens, i.e. alcoholism, is definitely an important problem, but the broader concept of excessive drinking or drinking, in ways that will impair you or can harm your health is a lot broader than alcohol use disorder. Point 3 is that treatment is definitely part of the solution for some people, but changing the broader environment is critical to make a big difference. So we really need comprehensive strategies with alcohol control policies as the critical part of that solution and the critical strategy. And we didn't get into this too much, but policies that target the whole population and that increase the price of alcohol and reduce its every moment of the day physical availability are the most effective types of policies. So with that, I'll wrap up my taped remarks. Thanks for hanging in there, and then I guess I'll be answering questions at the live session. Thanks again.